Tad, a registered radiology technologist. So for today's video, I am going to show you the two different types of the position of the leg and the shoulder trauma. And for the leg, I'm going to use the AP projection, while for the shoulder trauma, I am going to use the tangential projection, supraspinatus outlet shoulder trauma, or also known as the NIR method. And if you want to know more, just keep on watching. The first radiographic examination that I am going to demonstrate is the AP projection of the leg. And for its part 1, now I am going to show you the part and positioning details of the patient body. So for its patient position, place the patient in the supine position, which you can see here that the patient is already lying, which is in a supine position. Then after that, provide a pillow for patient head. Next is the patient leg should be fully extended. The rad tech should provide a pillow to patient head so that during the radiographic examination, he or she would be comfortable. And also, the leg must be extended. And for its port position, adjust the pelvis, the knee, and the leg of the patient into true AP with no rotation. Then, if possible, place a sandbag against foot if needed for stabilization. And dorsiflect foot to 90 degrees to leg if possible, just like this. Then after that, let's assume that this is the image receptor. You will going to put it on the affected side of the patient leg. Then after that, the unaffected side should be abducted from the affected side so that you could be able to put the image receptor on its proper position. Let's go on to the part 2, which is the central ray of the patient AP projection leg. So, the central ray must be perpendicular to the image receptor, directed to the midpoint of the leg. Its reference point would be the midpoint of the leg in this area. There is no angulations being used in this central ray. For the part 3, it's technique factors. The placement of the marker should be found at the right leg of the patient since the affected side of the patient is found at the right. Just like this. Then after that, for its collimation, collimate on both sides to skin margins with full collimation at ends of IR borders to include maximum knee and ankle joints, just like this, so that you could be able to get the right image for this position. There is no breathing instructions being used since I am getting the position of a leg, which is the AP projection. For its technical factors, minimum SAD should be 40 inches or 102 cm. It may increase to 44 to 48 inches or 112 to 123 cm to reduce divergence of X-ray beam and to include more of body part in this area. And for its IR size, it should be 35 by 43 cm or 14 by 17 inches lengthwise, or diagonal, which requires 44 inches or 112 cm minimum SID, non-grid, unless lower leg measures less than 10 cm. Analog is 70 to 5 kV range. And for its digital system, it is 70 to 80 kV range. To make best use of anode Hill effect, place the knee at cathode end of the X-ray beam. It has a 200 mA and the time of 0.01 seconds. And for its kVp, since the formula of kVp is patient thickness times 2 plus machine constant of 40, so let's assume that the patient thickness of the leg is 10, then the times 2 would be 20 plus machine constant of 40, it would be 60 kVp. And lastly, for the clinical indications of the AP projection of the leg is pathologies involving fractures, foreign bodies, or lesions of the bone. And for the next radiographic examination that I am going to demonstrate is the tangential projection supraspinatus outlet of shoulder trauma, or also known as Denier method. And for its part 1, the part and positioning details of the patient body. So, the first thing is, when taking the radiograph with patient, it should be in erect or recumbent position, just like what the patient doing right now. The erect position is usually more comfortable for patient. Next is the part. For its part position, with patient facing the IR, rotate into anterior oblique position as for a lateral scapula. Then after that, palpate the superior angle of the scapula of the patient and then also the AC joint articulation. Then after that, rotate patient until an imaginary line between those 2 points is perpendicular to the image receptor. Because of these differences among patients, the amount of body obliquity may range from 45 to 60 degrees. Center scapulohumeral joint to central ray and to center of the image receptor. Then after that, abduct arm slightly so as not to superimpose proximal humerus over ribs. Do not attempt to rotate the arm. So anterior oblique the patient slightly. After that, palpate the patient superior angle of the scapula, also the AC joint of the patient. After palpating, abduct the patient arm slowly as not to superimpose the proximal humerus of the patient over the ribs. Then after that, do not attempt to rotate the patient arm. And for the part 2 is the central ray. Central ray requires 10 degrees to 15 degrees central ray caudal angle, centered posteriorly past through the superior margin of the humeral head in this area. And for the part 3, it's the technique factor. The placement of the marker should be played at the examined area of the patient. And for its collimation, collimate on 4 sides to the area of interest. And for its technical factors, the minimum SID should be 40 inches or 102 centimeter, and the image receptor size would be 24 by 30 centimeter, 10 by 12 inches lengthwise. The grid should be vertical or central ray to center line. Analog should be -75 or positive to -5 kV range, and the digital system should be 75 to 85 kV range. AEC not recommended. So the MA for this position would be 200 MA and the time would be 0.01. And for its KVP, since the formula of KVP is patient thickness times 2 plus the machine constant of 40, the patient thickness of the patient arm would be 12, then times 2 it would be 24 plus machine constant of 40, it would be 64 kVp. And for the breathing instructions for the patient should suspend respiration during exposure. Ma'am, please inhale, exhale, inhale, hold your breath for a second, then shoot. You may now release your breath, ma'am.